welcome. This is the Institute of Health and Social Care Management and the latest in our roundtable series. And today we are looking at the future of primary care. We're absolutely delighted to be joined by Sian Thomas, who's Deputy Chief Operating Officer at Walsall and Wolverhampton NHS Trusts. We also have Dr. Bukola Olomolaiye, who is Deputy Clinical Director and Partner at Walsall and Wolverhampton NHS Trusts. And I can see lurking in the background as well, we've got Stephanie Cartwright, who's Group Director of Place from the Royal Wolverhampton and Walsall NHS Trusts. You're probably wondering quite why we have such a gathering of the Royal Wolverhampton. All that will become clear as we move along. We do have an apology, I'm afraid. Roy Lilley, who should have been on the panel today, is not feeling at his greatest, I'm afraid. He's got a bit of a streaming cold and is losing his voice, and he's resting up, so he's not going to take part today. But I've got some points that he thinks would be useful to raise, and I'll do that as we move along, okay? So Sian and Bukola and Stephanie, thank you so much for getting involved today. We do really appreciate it. Let me just give the audience, as they start to come in now, a little bit of background as to why we felt this was a useful roundtable event for us to host. First of all, July 2023, I don't know whether any of you've seen the latest stats. There were 27.8 million appointments for primary care. That's just GP appointments in July 2023. Now, these are in the last year, it's reported that a third of GPs are now salaried. That's right across the English NHS, for which I've got stats. Since 2015, the number of GPs has consistently fallen. It was 29,000 back in September 2015. Today, it's just north of 27,000. So we've had a drop there. I've done a little bit of kind of calculating, and I reckon if there were 27.8 million appointments in July 2023, given that we've got 27,000 GPs, I reckon that's 1,029 appointments per GP per month, which I reckon brings us out at 51.48 appointments per day per GP. I've got no idea whether that's right or not. Bukola's looking slightly concerned at those stats, so we'll see where that's taking us. Let's have a look at the model, though. I mean, clearly the capacity versus demand is not sustainable, as you've got the two elements going in opposite directions. Labour government or Labour shadow government has proposed scrapping the contractor model that has been the independent contractor model, which has really been the overwhelming model in primary care for many years now. There are several trusts now who are employing GPs, and Royal Wolverhampton and Walsall are going to explain in a moment why they're one of them and talk about their vertical integrated model. Merging has already started in Spain, the US, New Zealand and Denmark, and I think it's going to be interesting to find out now whether and how the Walsall and Wolverhampton model is actually gaining traction and with the sort of positive effects that we're having. So Sian, if I could come to you first of all, would you just give us a very brief overview in respect of what was the background to Wolverhampton choosing to adopt a vertically integrated model? Can you also give us an idea of the scale and scope now that you're involved with and how you've structured it? And then perhaps we'll go to Bukola and Stephanie to just put a little bit more information towards it. So would you mind going first, Sian? Thank you.
Of course, thanks, John. Afternoon, everybody. So the PCN RWT model conversation started back in 2016. 3 GP practices approached the trust, and we're always very clear to say this has not been an aggressive model of acquisition. This has absolutely been about primary care themselves identifying that they wanted to work with the trust, who at that point in time operated some tertiary, acute and community services across the city of Wolverhampton. Those conversations kind of rolled into practices joining the trust over a period of time. We now operate 9 GP surgeries across the city with a registered population of around 50,000 patients. We do operate as a single PCN. The kind of national language and policy around PCNs came in after we started this model. We are spread across the city. For those who don't know Wolverhampton, it is an area of high deprivation, high rates of ethnic diversity, and generally a population that is younger than the England average. And we absolutely see that represented in our PCN population. So we operate the city centre GP surgery, for example, that supports the homeless shelter, that supports all of the hotels that are currently housing asylum seekers and refugees. But we also stretch out to the west side of the city where you start to border into more leafy Staffordshire, and we have some of the highest numbers of care homes registered with our surgeries in that area.
That's very, very helpful, Sian. So what you're basically saying is the impetus for this wasn't Wolverhampton going to those practices and saying, wouldn't it be a good idea if you joined us? It was a more collaborative sort of approach based on both sides of it, kind of identifying this would be perhaps a good idea. Would that be fair?
Absolutely. This was never a model of acquiring failing practices. We weren't seen as a backstop in that model. We were very much working with GP practices who, looking forward, felt that they could see on the horizon that there needed to be a change in the model and were willing to try something different with us. And then more colleagues joined us as the journey went along.
Good. And have you included sort of community and mental health at all in this as well? Is that part of the integration, or is that a little bit separate still?
So following TCS, all of the community services in Wolverhampton moved into RWT. So we operate the citywide community services. Within my operational portfolio, I have 7 care groups, and primary care and community services are an integrated care group within that. And as the conversation moves on, we can talk about some of the benefits we think we've seen around community services being able to work with our PCN in a different way. But for mental health, other than the R's specific mental health practitioners that have come through that route, we aren't operating any mental health services.
Got you. Okay, that's very, very clear. So Bukola, could I come to you next? And then I'm going to come to Stephanie really to ask about the employment structure of all of this and how this works. But Bukola, tell us how you came into this. You're now the deputy clinical director. So, you know, you're a senior figure in all of this. How did you get involved in this as the idea in the first place?
Yeah, so I think it's maybe easiest for me to give some initial context in terms of me as a GP. So I've probably maybe been qualified around about 9 years or so ago, and I've settled into the practice where I trained, where I went on to become a GP partner. We are a practice in Wolverhampton with a population of around about 5,000 patients with, at the time, 3 GP partners initially. And just after the kind of vertical integration model was starting to get going in Wolverhampton, it coincided with a time in our practice where I suppose the bureaucratic load in terms of the day-to-day running of the practice was ever increasing. I quite kind of vividly remember things like GDPR coming in at the time, and actually dealing with those kind of administrative aspects was increasingly leading more and more to us spending less time as doctors dealing with clinical things, the things that you want to be, that you become a doctor for ultimately, and more times dealing with those administrative and bureaucratic aspects really. And so fortunately, the practice that I work in, I think, as Sian alluded to, we've not been a failing practice, been a practice that's been high achieving historically. But I think it came to a point where myself and my partner colleagues felt that actually there must be a different way to do this really, for us to be able to successfully look after our patients in a more coordinated way, and also have more time to be able to spend with our patients. And so that was the ambition from our own point of view as a practice, and that of my colleagues as I've got to know them over the years as well. And so that's that's the underlying drive, for us, integrating with the trust, and so that's hopefully what I feel has come to fruition, at least in part, in the years that we have been integrated, which I think is 5 years in total.
Let's just ask about what did your patients have to say? Have they commented upon this? Did they get anxious about it when you were telling them what was happening, or has it just been very much business as usual, just move along? What was the reaction from the patients?
Well, I think we're quite fortunate in a way, in terms of that actually the change to become integrated, although there may have been that initial anxiety, actually the makeup of the team here in terms of the doctors and the health professionals here has remained the same initially, at least, particularly with the doctors, and it hasn't changed. And so they can see that okay, the practice maybe runs in a slightly different way, but they're still having that relationship with the doctor that they've known all the way along. And so that continuity is there. And I think particularly in primary care, that continuity is really, really important to both to clinicians and also to patients, in terms of giving them that reassurance. So there have been lots of changes, and I suppose there've been lots of change. We've had a pandemic in the time that we've joined another one, really, so there'll be lots of changes anyway. But I think having faces like my own and my GP partner there along the journey has helped to kind of reassure and be able to talk through things as we've gone along. So I'd hope that the patients, if they have had any initial anxieties, they've been allayed by me hopefully being along there in the journey with them.
Got you. Thank you. Could I come to Stephanie and just ask Stephanie, could you help us understand the mechanics of employment now of the GPs and the ancillary staff and the nursing staff? Who are they employed by now, and how does that work? Could you give us an explanation?
Yes, I mean, Sian's closer to the operational detail of this, but the staff are employed by the trusts. So I've been working with the two trusts. The two trusts, Wolverhampton and Walsall, work together as a group model. So I've been working with the two trusts. I joined them a couple of months ago with regards to how they're developing their partnerships and integration. When you sort of ask the question about things like the community and the mental health, then we achieved that through the place-based partnerships and the integration at a place-based level as well. But the model that Wolverhampton have very successfully implemented from the GP's perspective, as Buki's just referred to, GPs up and down the country now are looking at what options they've got moving forward. There are, as you've referred to, there's less people coming forward, and there's less people that are interested in the traditional partnership model. And then you've got existing partnerships that are thinking, what is our business model moving forward? There's lots of national changes, as you're aware of, with regards to primary care. And what I've heard a lot of the GPs say is the comfort, actually, of having a bigger organisation around them to rely on. So there's quite a lot of pressure on independent practices and businesses to kind of deal with the pressures that they're dealing with. And one of the things that vertical integration brings them is that wider support network of the trust. So all the corporate infrastructure that can help, the business management expertise, HR, just things like that come with this kind of model, I think shouldn't be underestimated. I think the other benefit of this, which you might want to come to, is the opportunity it gives with the interface between primary care and secondary care. So you think about populations are 95% of healthcare contacts happen within primary care, and actually there obviously patients are registered from cradle to grave. The other elements of their treatment come as episodes within their kind of lifespan, whereas primary care is with them throughout. So the primary care model, I think, for the future, needs to be sustainable, because that's what kind of keeps people out of hospital and wrapping those services around them. But actually giving practices options to be able to continue a business model, but with that support of a kind of larger infrastructure around them, I think can be can be incredibly attractive to some practices. If you want, do you want some more of the detail on the employment model with the staff? Sian, do you want to answer some of those questions?
Yep, that's fine. So all of our non-medical staff were transferred onto Agenda for Change. We do have to be very clear that created a cost pressure. However, we felt that was very important for equity of pay across the organisation. Yeah. Interestingly, we are finding now that actually in some ways Agenda for Change can tie us to a lack of flexibility. So while there's potentially greater benefits around pension, sick pay and annual leave, with the current economic circumstances, cash in hand can be more important, and that's, you know, absolutely understandable. So we are now seeing kind of rates of pay potentially being offered that are higher in primary care, lacking some of the softer benefits, but that kind of long-termism isn't necessarily the most important thing to people now. Our medical staff are all employed by the trust, both the partners and the salaried GPs. They are on local contracts that are standardised across all of the GPs, and we're just starting to instigate a process of GP job planning now to bring us in line with the wider organisation. In terms of the employment model, so absolutely everybody in primary care knows that they are within the primary care team, but we do link our professional groups into the wider organisation. So, for example, one of my other care groups is pharmacy. So the chief pharmacist sits in my portfolio, and another one of them is all allied health professionals. So the chief AHP sits with me. So those first contact physiotherapists, those prescribing pharmacists that sit in primary care, they are all professionally supported by our chiefs, and they have the opportunity for rotational roles. They have access to the kind of training and developments that are offered trust-wide, and we think that's one of the real strengths of our model. That same opportunity is given to our GP colleagues, so they have access to the same leadership development courses, portfolio careers. So, for example, one of Bucky's GP colleagues, Hassan, does sessional work in our occupational health department, supporting our staff across the piece. So kind of lots of different opportunities, but fundamentally we've standardised the employment model.
Thank you very much. That's a very comprehensive answer. I really appreciate that. Look, you are not on your own here, are you? You know, there is a similar model now being rolled out. Well, it's been rolled out in Northumbria, I think. There's a similar model then down in Somerset, where I think they've set up a dedicated separate company, but it's still on an integrated basis. But then you've got different models slightly, where you've got the private provider operos who've been buying up, if that's the right terminology, practices elsewhere in the country and grouping them and kind of going for a mass as the model, which would have benefits in terms of buying and recruitment and employment and the bureaucratic stuff that Bukola was referring to. I mean, I've got to ask the question, are you finding this successful? Are you happy with the results that it's giving you? Do you genuinely now start to think, well, actually, we're just the first of, you know, any number of dominoes where, you know, there's no going back here. We wouldn't want to, well, it would be impossible basically to revert to the original independent contractor model now and kind of reverse out of this. Don't mind which one of you takes that rather elaborate question.
Well, I'll go first, and then I'll hand over to Bucky, because he can speak most eloquently about what it means for him. I think I would be very keen to say we are not advocating this model works for everybody. And absolutely the localism and the ability to have variation in the primary care model, I do think is very important. I think we have had quite a few successes. All of our GP surgeries are CQC rated good. If you look at kind of telephone response times, we're probably doing the best in the city. However, we aren't cracking some of the fundamental issues. We do continue to have, you know, challenges around workforce development and recruitment, given the limited market that is out there. But fundamentally, we're committed to this long term. We can see lots of benefits. We have participated in a couple of research studies. So we are waiting for something to be published by, I think it's RAND and the University of Birmingham, looking at outcomes.
Yeah, I think really, NIHR are looking at a study as well, I think. So, yeah.
Yeah, absolutely. And I think we have to put our hands up and say, quantitatively, we're really struggling to demonstrate it. COVID has had a big impact in that when you're trying to look at longitudinal change. We are seeing some statistically significant differences in emergency department attendances and conversions to admissions. But it's like just crossing the P threshold for those who are into statistics like me. But outside that, the measurables are really hard.
Super. Thank you very much. Bukola, could we come to you? What's your experience of this?
Yeah, so I mean, I think as Sian's mentioned, it's not a gospel that we're trying to spread as such, really, in terms of a model that we're saying can easily be replicated elsewhere. I think going right back to the start, it's kind of come out of those relationships initially, and as you say, primary care being in a position and secondary care, in the case of the trust, being receptive in I'd like to think a relatively unique way to serve a particular population. And so I don't think we can, I suppose even in the examples that you've given, it's difficult to compare because they're not exactly the same as this particular version of medical integration. But going back to your point in terms of how I would reflect on it, yes, I think it is tricky, as Sian has said, to maybe put a finger on really clear, objective things that are better. But I think in terms of how talking personally, in terms of my experience, it's not a decision for us to be integrated that I look back on negatively, and I can see the growth and the opportunities that actually being integrated with the trust has provided that perhaps wouldn't have been available to us as a partnership, as a traditional partnership. I do believe that with some of the services that we've been able to get started since integrating with the trust, such as having a home visiting service, the opportunities that are available through working closer with the community trust, those things have, I say, brought partially to fruition the ideas and hopes that I had and our partnership had in terms of reducing the bureaucracy and giving us more time to spend with our patients. That doesn't translate into, as Sian has touched it, into that our patients that all our patients ring up and they get an appointment straight away, and that's not quite the case. We still experience the same struggles and challenges as primary care at large nationally. But I do think that we have been able to develop and deliver at least partially in terms of how things feel and provide opportunities to GP colleagues that I think would say the same as well if you had them on this call. And I think comparatively as well, looking forward to the future, I do believe that there are opportunities in this model to develop primary care and to innovate in a way that, particularly if maybe talking from a practice that was a 5,000 patient practice with 3 partners, there are less opportunities for us to. It's more about kind of treading water than being able to think innovatively, really. Whereas actually that becomes an option when we're working within a model like this. And so, as I say, I would reflect positively. It's not to say it's always been a road without any bumps on, but I would reflect positively on that decision.
Thank you, Stephanie. Could I just ask you, what's been the reaction of are you aware of the reaction of other primary care providers in and around Walsall, Wolverhampton, Staffordshire and so on? Have they been in touch? Have they been contacting you? Are they interested? What's been the sort of wider health environment reaction to it?
I would actually say it's mixed, actually. I think so within the Black Country, so Walsall, Wolverhampton, Dudley and Sandwell all operate within the Black Country. So Sandwell operates a similar model. They've got quite a significant partnership that decided to follow a similar path. And I know that some of the practices within that area will be considering it. I think it's mixed. I think there are some practices that have a concern that this is an acute takeover, and that's one of the things I think that they need to speak colleague to colleague, and that's where people like Bucky and some of the other GPs can sell it best, really, to be honest. I think, as Sian said, this has never been about an aggressive kind of takeover strategy of primary care by secondary care. This is about offering something to secondary care, but I think sometimes, unless people get close enough to the model and understand what it's like, it can be perceived, and often I think we all know perception sometimes can be greater than reality or stronger than reality. It's perceived as secondary care or acute trust trying to take over primary care, and that's really not what it is. So I've actually been incredibly impressed, because I've worked around the Black Country and then joined this system. I've been impressed that it's not a predatory approach. It's from the executive team and the board's perspective of the trusts. This is about a supportive mechanism to primary care, and I think that's a really important message to get across to people who are considering it. I think some concerns across GPs are that they're going to lose autonomy, and I've not seen any loss of autonomy from the GPs that I've spoken to within these practices. If anything, I think that they feel like they've got support and assurance, and like I said earlier on, a wider organisation to be able to feed into development opportunities that can be career structures that can be formed for GPs that aren't necessarily always available in a smaller partnership. So I think for me, it's always about talking about the opportunities. Like Sian says, it's not always plain sailing. There are some things that need to be worked through as you go through this. But I do think there's a bigger opportunity here. The bigger opportunity, I think, is also about that integration and that interface across the primary care and secondary care that this brings. But so I think it's mixed, John, to be honest. I think,
Right.
Like I say, some people see it as predatory. Some people see it as a trust just trying to accumulate practices. Whereas actually, I would say the vast majority of trusts that have done this are doing it as a supportive partner within their local system, where they're seeing that primary care is looking for different options for the future. They are an option, and it's kind of all about the culture of that trust, about whether they will reach out to be an offer to those practices. The people that sell it best, though, definitely the GPs, because it's really about what does it mean to them and what's it meant for them as regards to their profession, the way that they see their patients, the way that they run their practices, and they're the best ones to answer those questions.
Thank you, Stephanie. Well, look, this event, we're in partnership today with our primary care hub, which is Williams Medical, and obviously Williams supply equipment and consumables and all sorts of stuff to primary care. Can I come back to you, Sian, and say, look, what are the implications here for sort of supply chain, for things like logistics, IT, procurement, equipment and so on? What have you done? Obviously that would have previously been the domain of probably the practice or business manager in individual practices. How has that now evolved given your integrated approach?
So I think this is very much a tale of two halves. So all of that infrastructure is supported by the wider corporate teams within the trust. So our procurement function, our purchasing function. So in many ways, we'd like to say we think that's raised the standard, the consistency and the quality of what we're purchasing, providing, how we're doing it, an alignment with our teams for easier interoperability, say, between community care and primary care. However, I'd absolutely, the other side of the story is that is slower. Yeah. We have taken away some flexibility from primary care because an independent GP business, fundamentally is subject to a different level of expectation on how it complies with OJU, whether it's even required to, what the CQC would expect of it in terms of disability access to a premises and infection prevention and control. An £800 million trust, which RWT has very different standards that it is held to, and there has been a rub trying to put those same standards into primary care. So, whereas Bucky before might have been able to, and I don't mean to demean this, but, go down to Staples when Staples used to exist and, change over a number of pieces of equipment. We can't do that now. You've got to go through, chosen suppliers, through a system that has a process and has a certain approach to sign off, and a higher quality office chair doesn't necessarily always negate the fact that it's then taken 3 months to buy it.
No, I kind of, that was part of the interest. Could you talk to us a little bit about the IT infrastructure as well, because clearly GPs, in common with care homes for that matter as well, and other residential care providers, they've had this patchwork of different systems. They've had different operating systems and EPR systems that they've been using. Can you just briefly tell us how you've approached all of that? So presumably you've gone for a consistent one-size-fits-all approach.
So from an EPR that was already in place, EMIS is the provider across the whole of Wolverhampton for the core EPR. Right, that hasn't particularly been affected. I think what we have been able to do is support our PCN to innovate at a different rate, and we've often been the PCN that has trialled new things first, because it can be supported both technically from a larger in-house IT department, but also from a financial point of view in terms of the risk appetite of the trust. So as an example, we implemented cloud-based telephony both before it was mandated for primary care, and we very much did that at our own financial risk. Very interestingly, now it's been mandated and some money has been made available. We're being told we can't retrospectively ask for it because we took it upon ourselves to sort. So,
great. And what have the CQC made of all of this? You referred to the fact that recent inspections have been good for all of the practices involved. Do the CQC now view you as Walsall and Wolverhampton as a vertically integrated model, therefore they inspect you as one, or will they continue to inspect separately the individual components?
They continue to inspect separately the individual components, and it is fairly challenging to even get them to link in sometimes with our corporate structures,
I bet,
rather than writing
yes,
to an individual staff member at an individual practice.
Yeah, I mean that to my mind, I'm just thinking that through, and I mean that's flipping challenging. How you persuade them that actually a lot of the, you kind of call it corporate activity within Walsall Wolverhampton is now going to be responsible for some of the key elements that they would ordinarily have inspected at a very local individual level. So yeah, I don't quite know how that's going to evolve, to be quite honest. Well, look, anyway. We've got a couple of things in the chat, and if you're in the audience and you'd like to raise some questions, you know, this is a roundtable event. I've kind of hogged it rather for 33 minutes now, but Ian has said, I think he's NHS Southwest London, is that right, Ian? You've said, how did the commissioners in the ICB react, and how are they dealing with funding the practices, or is this really just an employment arrangement that doesn't affect the primary care contracts with the practices? Presumably the practices still operate individually as GMS, PMS. I mean, you've sort of answered that, Sian, but would you like to give a view on that question? You're just on mute at the moment, Sian, forgive me.
It was going to happen once, wasn't it? But hey ho. So all of our surgeries are under a GMS model. We've never held PMS or APMS. We are merging our GMS contracts into a single contract, and we think strategically going forwards that will help us on a number of fronts, but that's something we're doing over a phasing of several years. So we've just merged 5 of the 9. We're about to start on the next 2, and then we're working over the next year. So in terms of the funding model's exactly the same for our practices as it is for any other, but the monies flow into the trust like they would for a T&O budget, or like they do for my district nursing budget. And then primary care is set a budget like any of my other services are, that is based on the kind of funding and income that is generated.
And could I just kind of building on Ian's point, what have NHS England said about this? I mean, are you aware of any comment or encouragement or concerns that they may have had? I mean, this is groundbreaking stuff in terms of, well, a remodeling of the entire approach to primary care in what is a very significant size geography. You know, how are NHSE looking at this? Is this playing to their own development manual, do you think, or are they looking at this with some anxiety?
So strategically, they are absolutely supportive of this, and we've had visits from a number of colleagues. Yeah. Unfortunately, that strategic support is not translating into the day-to-day pragmatics being made any easier. So just to give you an example, primary care estate has access to small pots of money for maintenance and improvements. our capital budget as a trust was not uplifted to recognise the fact that we took on those surgeries. So we still have to operate through that mechanism. That mechanism is very much reliant on a GP contract holder having a responsibility in terms of the lease holding for the building. So although all of the GPs are our employees, up until this last year, we had to have our employees sitting on leases for buildings. I mean, you couldn't imagine an orthopaedic surgeon sitting on the lease for the theatre he was operating in, could you? But our GPs have had to sit on leases for the practices they're working in order to make sure that we didn't lose out on the opportunity to bid for primary care estates money. That's taken a significant amount of effort of working with local estates teams to get them to understand strategically what we're trying to achieve. And actually this year is the first full financial year where they've agreed that the trust can be the named principal person on the lease as long as we have one GP contract holder, and that person can be the figurehead on behalf of all of our sites. But that's probably taken 18 months work.
Good grief. I almost as soon as the question was out of my mouth, I was thinking, oh gracious, I think I may have just kind of, created a new Gordian knot for us all to try to mess around with. Stephanie, yes, you've got your hand up.
I mean, I would obviously agree with Sian. I think the intent is there. So we do a lot of calls with NHSE colleagues, national colleagues who are looking at the primary care model. So they're definitely encouraging of this model in the future. They definitely know that for many primary care colleagues, there needs to be some options moving forwards with regards to the sustainability of primary care, given the stats that we covered earlier on in the meeting. I think one of the things that just picking up on the question in the chat and the contract is what they were developing a few years ago was the development of the integrated care provider contract, which would enable an NHS trust to actually, so the GMS contract would move into the trust. Yeah. That I think is the next stage that really needs to be developed, really, because it's at the moment an NHS trust can't hold. They can hold APMS, but they can't hold the GMS contract. And I think that's one of the things that we talked to the national team about would be incredibly helpful to enable the model to move on to a different level that would hopefully alleviate some of the areas of issues that we encounter because of the model that is currently the only one that is available. So it was some work that they did some years ago on that, and I think they're still looking at it, but there needs to be some traction behind that, I think, because it would give more choice and flexibility to both the practices and the trust.
Perfect. Thank you, Stephanie. There are a couple of more questions pinging in here now. So you may have seen Pam Smith. Hello, Pam, from down in Cornwall, I think. How do you handle T&Cs? Do your practices all use A4C? God, we all love an acronym, don't we? Would any of you be able to answer that at all?
I think Sian's covered that. A for C is Agenda for Change, and I think Sian's explained that all the staff were moved on to Agenda for Change contracts. Thank you.
And Christine has asked, quite rightly, were there any redundancies like practice managers and so on, or have you just moved them all across? How's that worked?
So no, there weren't any redundancies. We've always been very clear that there are some changes we'd like to make to the model, but this was absolutely not about putting anybody at risk. And so anything we've done has been through turnover.
Thank you very much indeed. Well, look, I've got to ask the question then. Is this the future? Do you think that there's enough positives coming out of this, and it's meeting a building up demand from GPs who are partners who are aging and want to get out, and you've got this situation where a lot of newer GPs coming through don't want to be partners, so you can see there's pressure building for the future here. Do you think this is a model that actually 10 years from now we'll all be thinking it should be unusual if you weren't within a vertically integrated NHS model? Who'd like to go on that one? Bukola, I've ignored you for the last 10 minutes. What's your thought in that regard?
That's quite That's quite
Yeah,
right.
yeah, have that one. Yeah.
I hope it's the future. I'm a GP for I've got another 30 years or so to go. So, no, but I mean, seriously, I think it's a future. I think, like I said, I think there's certainly enough that I've seen, to believe that this is a solution to some of the issues that the primary care is facing, and we have had some success. When we're thinking about what GPs are thinking, and perhaps maybe being less interested in terms of some of taking on some of the burdens that are traditionally associated with the partnership model. Actually, then that makes this model hopefully attractive to colleagues.
Has it made you feel better on a daily working basis? I mean, the pressures of running a GP practice as a partner, responsibility for several of the things that you've spoken about so eloquently and so on. It's a high stress environment, a typical primary care practice right now that's self-owned, as it were. Have you found that a lot of that pressure has been lifted off of you?
Yeah, I think for me it comes down to why I became a doctor, really. So
exactly.
I think
that's what I was trying to get to.
Yeah. So because ultimately for me, if I have more time with my patients, then I'm a happier person, because that's what I want to do. I think that is true for most of my colleagues as well. That's why we go into the profession that we do. So I think a model that facilitates that and makes that possible, to me, should be well received. And so that's my experience of this particular model. As I hope that that'll be the same for the colleagues. And there's lots of partnerships across the country that are very successful, and still successful as well. But I think that the future at the moment, particularly in terms of the drive from above, seems to be a push towards working at scale. And so if you think about 10 years from now, I don't anticipate that there would be many practices like my own traditionally, in terms of the 5,000 patient practices with one or two, well, with 3 doctors and a single nurse. I don't think that's the future of primary care as anyone sees it. And so actually, if we're moving towards working at scale ultimately, then I think this is an attractive model for the future in terms of working at scale and delivering primary care in a more sustainable way, ultimately, to enable doctors to spend more time with their patients and hopefully be happy with what they're doing day to day.
Well, you look well on it, I must say. You're smiling, your skin looks good, you look relaxed, you look calm and considered, you speak nicely. You must be something's going well for you, so there we are. Stephanie,
very kind of you, John.
Same question to you, Stephanie. What do you think?
So I would say it's one of the models and one of the options. I think, as I said earlier on, I think there is concern from within some primary care that this is a huge takeover. And I don't think that's what this is about. This is about, in that local place, those local primary care practices coming together with a local provider and a local NHS trust that can offer them another business model for their practice. And as Buki just said, people go into primary care and being a GP for a reason, and that's to look after their population and their patients, etc. So I think that this is one of the models. I think there will be a number of models that we see come forward. But I think what I would encourage people to do is find out more about it. And there's a question just gone into the chat actually about that, because as I said earlier on,
Ed was asked the key question, yeah.
It's easy if you're outside of the model to make perceptions about the model that aren't necessarily true. So what I would say to people is to find out a little bit more about it, to speak to people within the practices, to speak to people within the trusts. But I think this is a very favourable model moving forward. I think it brings economies of scale, but it also brings greater efficiencies for the practice because they're supported by wider teams. And I, personally, I would be an advocate of it. But I think, people need to be able to find out more about the different models that are available, and think about that fundamentally the sustainability of primary care moving forward. Because without primary care, the rest of the system just doesn't operate if
Well,
primary care isn't operated. It can't.
I mean, primary care is the gatekeeper, isn't it? You know?
It is. But unfortunately, you know, it's not sometimes seen in the prominence that it needs to be. So it needs to be protected, it needs to be developed, and it needs to be given options to become sustainable. And this is a very attractive one.
Thank you, Stephanie. Sian, I'm going to let you answer the original question as well. I mean, I just can't imagine if I was a GP like Bukola, let's say I don't know, late 30s, early 40s, something like that. And I'm thinking, actually, the sort of lifestyle that I would be able to enjoy if I didn't have the trials and tribulations of basically being a small business owner, and I could just concentrate on doing what I went through medical school for, I'm just going to be thinking, where do I apply? You know, I'm going to be salaried. I'm going to have all of the different pension stuff taken care of. I'm not going to have to worry about all the employment stuff and data stuff, and I'm not going to have to get up in the morning and lick stamps and so on. You know, this is all of a sudden, all of the stuff that used to just absorb my attention, I'm just kind of park that to one side. I mean, perhaps I'm just kind of putting words into your mouth here, Sian, but do you understand what I'm driving at? I just don't understand why you wouldn't be being knocked over by other people in the rush to say, where do I apply?
So we have actually just had very successful recruitment this year, and have actually slightly over-established on GPs for the first time. I mean, I think one of the things we perhaps haven't mentioned is the financial liability. So while Bucky's spoken about, you know, the administrative burden, actually all of our GPs are employees now, so their personal income isn't dependent on how their practice performs. Now, for some people that will be a negative, because equally there's no opportunity to increase your salary. However, equally there is no risk, but also you are not sitting with a personal financial liability of the cash flow for paying your staff, or what happens if the boiler in your surgery breaks and you own the building. So all of that financial liability is now managed by a much larger organisation. We are definitely seeing that the younger GPs coming through and not wanting to buy into that partnership model. So that is where we are seeing kind of a successful recruitment, particularly because, and not meaning to make a generalisation, but sort of people of my age are more interested in a portfolio career. So far more doctors wanting to work part-time, wanting to do it in partnership with something else. We also offer the flexibility of working remotely for some of the shifts and doing the care online. So we are trying to be as flexible employer as possible. In terms of the question from Edward, I think you're kind of asking if you wanted to talk to someone in your area about how you'd pursue this. You've got to email the CEO of the trust.
I think
this was fundamentally driven by our CEO, and you know there are risks in this model. We have spent money over budget to achieve this, and there's been a lot to work out, like some of the examples I have given, and without the chief executive fundamentally believing this was the way forward for the organisation, that wouldn't work.
I absolutely endorse that. I know how hard Professor David has worked at this. I can absolutely say, without him leading this, and I might add as well, supporters from the local authority, community health, and so on, who all see the benefits of integration as well. This can't work. But Edward, to answer your question, look, if you don't ask, you won't get. So if you're looking at the future and thinking, actually, this is really rather attractive, whether you be a GP or a practice manager, practice nurse, whatever it may be, I think start writing some emails to your local chief executive would be the answer. Okay, would anybody like to unmute and just ask a question? I am going to come to Kieran from Williams Medical Supplies in a minute and let him ask a question, and he may want to also help me with the wrap up of this session. But does anybody like to unmute and maybe ask a question? Just put your hand up directly, and we would be delighted to come to you. You're not going to get a better view of how this works in real time than these three people I've got in front of me now. Hello, lovely to have you with us. Would you like to ask a question?
Okay, thanks very much. Happy to repeat what I put in the chat. One of the things that interests me, and in Cornwall we've got very much and have been working hard to maintain a partnership-based model. Frankly, because historically some of the relationships between the trusts and practice have not been as healthy as they clearly are, in your part of the world. And I think the bit that I'd be interested in is, have you as an organisation been able to be locally responsive to sort of shift investment so that you've actually enabled local variation to respond to different population needs, rather and actually demonstrate at a practical and financial level the benefit of integration in moving the system, as opposed to it perhaps being seen as practices, frankly, I think sometimes do, as a bit of a takeover, and that they'd be required to do everything the same and all this sort of thing.
Sian, would you like to take that one? I think you have kind of partially answered this, but would you like to have a go?
Yeah, so I mean, the example of the cloud-based telephony is one where we didn't get any money to do that. We didn't take anything out of the primary care budget. That was kind of taken from my budget at large. Absolutely, there's flexibility for practices depending on their local needs, which I think is really important, as I said, because we're not a homogenous PCN. So our practice in the city centre that supports asylum seekers, refugees and the homeless hostel, about 18 months ago now, when they started housing asylum seekers and refugees outside of Kent, Wolverhampton was identified as somewhere that was going to take women, children and family groups. We now have 2 hotels that between them have up to 500 people at any one point in time. When it became apparent that that was the level of what was going to happen in the city, there was a lack of clarity on the funding and on the support. So our city centre practice has got all of those people registered, and anytime there is movement, we register it. And that's because we've been able to move some of my community resource. I also manage all children's services. So for the pregnant women, the young children, kind of the health visiting, the midwives, they've gone in and we've been able to ride that financial risk to make sure we're supporting that highly vulnerable group, while nationally they've figured out how we're going to be paid for it. Thinking about the more affluent side of our city, where care homes is kind of the more important issue, we've deployed remote monitoring technology across the city, like many areas have. But when our GP surgeries close at night, that remote technology is then picked up by our 24/7 community teams, who make sure that those care homes have a route to escalate that isn't 999. We are always trying to offer what we do to the other PCNs, so that equally our PCN isn't seen to be at an advantage unfairly. So we've offered that out of hours cover to other PCNs. There are 6 in the city and 3 others have taken it up. So again, we always try and kind of offer out that as well. So we've got both flexibility within the model, depending on our local need, but also where we think something's working, we try to offer it to the PCNs that aren't part of our vertical integration as well.
Thank you, Sian. Again, hugely comprehensive answer. Thank you. I hope that answered your question, Pam, and best wishes down to call as well.
Thanks very much.
Edward, you were next with your hand up. Thank you, Sam. Edward, you were the next. You got your hand up. Laurel Bank Surgery, would you like to ask your question?
Yeah, thank you. Thanks for everyone for your input today. My question is more about what it's enabling you to do that I genuinely feel practices struggle with, that are, say, like myself, an independent contractor practice, around health informatics and patient monitoring, patient outcomes. And I'd like to know if you bother with QOF for what it's worth financially, for example. But also, do you have, with your structures and your teams, a way of really trying to monitor and improve quality within the primary care delivery because of what resource you have at the trust level, which practices just don't have the skill or resource, and I don't think the ICBs do either, to be honest.
Great question, Edward. Thank you very much. Stephanie, would you like to take that one?
I think that's best with Sian and Buki, actually, because that's the
okay.
Buki's in a similar role and Sian's got the support around that. Buki, do you want to go first?
I was going to say, let's give Sian a rest, Bukola.
Yeah, of course. So yeah, I think to answer your question, in terms of informatics, being integrated with the trust has enabled us to maybe have a specific IT input. So whereas, if you think about something, QOF is probably a really good example. So actually, as a GP, I would be involved in the clinical delivery of QoF and also counting the numbers of measure and doing the monitoring as well. Whereas actually within this model, we have a dedicated information and performance team who are monitoring that data. Within my role as Deputy Clinical Director, I'm able to plug into and provide clinical support to that team as well in terms of interpreting that data, and we're able to use that to be able to pick up on how we can support our practices best. And so it enables us to be able to hopefully deliver on things like QoF more efficiently and using up less patient-facing time, if you will, if we think about all our GPs across all our practices altogether, in order to deliver still good health outcomes for our patients as well. So particularly in the last year or so, we've delivered quite well on QoF as well. But it's, I suppose, if you're thinking outside of just simply those clinical markers as well, I think there's been opportunities when we think about innovation to be able to kind of use data both within secondary care and primary care to help support our patients better. So I think recently we've had we've been piloting a model where taking data from our secondary care admissions and using data for those taking it back into primary care and seeing who our frequent attenders are, and to be able to interpret that to see and support patients and maybe anticipate patients that are nearing the end of life, so that we can pick up on those patients quicker and be able to provide them support. So using that data across both secondary care and primary care to be able to deliver better clinical outcomes to our patients as well, which is, as I say, possible through what we're doing.
Thank you, Bukola. Sian, you got your hand up nice and quick, please, because we got Malcolm standing by with a question. I've only got a couple of minutes left, so.
Yeah, absolutely. So just wanted to give people a sense that what we're talking about is very much real. So I was just going to quickly share my screen. So we are able to integrate our data. So here is 3 kind of real examples. So every single morning, we're able to say who from our GP surgeries attended yesterday, what they came in with, what their outcome was. So our surgeries aren't kind of waiting for those discharge notifications, and we can respond very tactically. We also have something here called our GP triage management tool, which Bucky was referring to around risk indicators. So this sits between primary care and our community services and allows both for a risk stratification approach, but also a GP local knowledge approach for patients to be flagged, put into an MDT, and then transferred to our community services if we think we need the wider MDT involved.
That's fabulous. Thank you, Sian. Malcolm, thank you for your patience, waiting in the sidelines there. Very quick, if you don't mind. Short question would be marvellous.
Okay, quick question. My main area of expertise, by the way, is in digital health, but my question is not focused on that, even though it's had a couple of mentions. I'm just wondering whether the model has allowed for or encouraged the taking of a more strategic approach to the provision of different kinds of health services. I'm just thinking in terms of the way that people's health literacy can be built and the way that preventative health can be given greater emphasis, bearing in mind the particular needs and characteristics, no doubt, of Wolverhampton and Walsall and so forth. And how does this square with the outcome measures that you obviously have to produce in order to justify your existence and all the rest of it?
All right, that's quite a complicated question. It's a great question, but it's quite a complicated one. But Sian, would you like to have a quick bash at that?
Yes, so I would say, again, we've got the slight benefit of scale here in that we do have a dedicated communication and engagement officer in the PCN that's linked into our wider corporate function. She's been able to work far more comprehensively with our PPGs, for example, to develop our website and our patient education materials. When we're developing our new digital solutions, picking up on your area of expertise, she has therefore a group that she can test them with. We have tried running some patient education sessions, for example, on how to digitally engage with your practice to make sure that people aren't digitally excluded. She's fairly new in post. Would you say Bucky Chase has been with us coming up to a year? But you do quite a lot of work with Chase, don't you?
Yes, yeah. So as you say, I think we're probably about 9 or 10 months that she's been with us, and her impact is felt in the way that you've described.
I think, if I may, the answer to your question, Malcolm, by the sounds of it, is plenty. You know, I think it's enhanced that ability. Absolutely. You know, based on the scale and so on, and the professionalism that I know Wolverhampton and Walsall both apply to this. So, but
we
that's
would love
great.
to do more. We would love to do more. It isn't enough, but
Perfectly put, Sian. Thank you. Kieran, are you there? Would you like to just say a couple of words on behalf of Williams Medical at this stage?
I am, John. Thank you. Yeah, just on behalf of Williams Medical, I'd like to take this opportunity just to thank everyone who's contributed to the discussion and also attended the event. As an organisation, we're really passionate about primary care, and I think everyone will agree this has been an excellent platform to discuss what the future of primary care should look like. So thank you, everyone.
Thank you, Kieran, and thank you, Williams Medical, our partners in putting on this event today. Look, that's it. Goodness me. I mean, I'm blown away by what you've done. I just repeat myself from earlier. I'd just be forming an orderly queue at this point to kind of find out more and figure out whether that's going to be possible wherever I might be working. But let's not go over old ground. I'm hugely grateful, Sian and Bukola and Stephanie, all from Walsall Wolverhampton NHS Trust. Look, we couldn't have done this without you, and the insights and detail that you've provided, absolutely exemplary. Thank you so much for giving your time and your expertise in that regard. It really has been invaluable, and if anybody's wanting to know what the future of primary care might be, I really don't think you could have come to a better environment and a better event than this. So I would expect this to be quite a popular catch-up one on the recording, which will be going out probably middle to end of next week, something of that nature. But thank you, Walsall and Wolverhampton. Please give my best wishes to all in the Black Country. That's it from us for today. Thank you so much. You've been in the audience or you're watching on catch-up. I do hope you've enjoyed that. Wow, that really was box office. Thank you so much to all of you. Have a super weekend. Bye-bye.
thank
Thank you,
you.
everybody. Bye-bye.